right, good afternoon, everyone. I know it's after lunch and we're a little tired, but just stick with us and we'll get through this information as efficiently as possible. Today we'll be talking about beyond standard practice, bridging the divide between patient desires and clinical decision support systems.
So I'm Moriam Yarrow. I'm Senior Manager at Incenna, a health tech consultancy, as well as the President and co-founder at Yo Scholarship Foundation. It supports African American students with educational attainment.
And my name is Chinonso Ahananu, but the cool kids call me Chino. I'm a health literacy and patient education enthusiast, and I currently work as a clinical trials diversity specialist at Acclinate, where we help pharma companies, biotech companies, and other companies alike enforce and implement their diversity action plan.
All right, so today we're going to talk about how clinical decision support systems are a vehicle to deliver and execute standard practice. But however, bias and lack of representation and inclusion in research negatively impacts patients' experiences and desires and overall health outcomes. So first we're going to start off with, what is CDSS?
All right, so when we think of CDSS or CDS systems, think of them as the GPS for healthcare professionals, right? Essentially, it's very imperative for them to be used to help healthcare delivery, and they enhance medical decisions with targeted clinical knowledge. So a traditional CDS system starts off with individual patient characteristics. They're matched up with computerized clinical knowledge. And then after that, the information that the data system spits out, if you would say, is now then used to give the clinician or provider a decision. And then now that decision is now passed on to the patient. So when you go to the hospital or urgent care and they give you that medication summary, or they give you that packet at the end, you know, your discharge summary, typically most of that information is derived from a clinical decision support system. And some more specific uses are for computerized alerts and reminders, diagnostic support, medication management, chronic disease management, clinical workflow optimization, and patient empowerment. So just like we want patient care to be accessible, we want it to be fast, that CDS system does help out with that as well.
So there are a lot of benefits to CDSS systems. So they increase quality of care. It allows providers to have access to a knowledge base that, you know, I'm sure they can't cram everything in medical school in their brains. It also allows the avoidance of errors and adverse events. So if a patient has allergies with the medication, that system can alert the provider or alert the provider to make sure that, you know, there aren't any interactions. Additionally, it helps enhance efficiency for healthcare practitioners, so streamlining the workflow, automating routine tasks, and also just providing the most relevant information, and then improving resource allocation. And it has seemed to be effective, and there's still growing bodies of research to show the effectiveness of CDSS systems.
And just like there are advantages to things, there's also disadvantages. So with CDS systems, before the algorithm is even formed or created, it's already built on biases. Race biases, sex biases, gender biases, which sex and gender are not the same thing. All these biases based on old standard practice perspectives. And because of that, the information that is, I guess, outputted isn't necessarily substantial. It's not updated, it's not upgraded based on the medicine that we practice today. And with that, that can lead to limited personalization. So the data is meant to, you know, help the patient, but if it's not properly equipped, then that information cannot really, you know, be as helpful, if that makes sense. And when it comes to the patient care experience, although CDS systems are very reliable and they do help a provider be very efficient at what they do, it does limit the opportunity for them to really speak to the patient. So when they're in that room, you know, studies show that the average time spent with that patient-provider, interaction is about 15 to 17 minutes. 5 minutes for the provider to speak, 5 minutes for the patient to speak. And there's only so much someone can say in 5 minutes, Just like it was mentioned earlier, by the time the doctor leaves, you may have 2 or 3 questions that you couldn't even ask. In my personal experience, I went for a PCP visit, and I was sitting in the waiting room for about an hour. And then when I finally got to the patient room, I was there for another 45 minutes. And then once the provider came in, it was literally like a 5-minute interaction, and boom, she was out. So I had to go home, TikTok, Google, figure out what was wrong with me, just like many of us do. And at the end of the day, that made me feel like, what's the point of rescheduling a visit? What's the point of going to the doctor if I can just search up my symptoms or search up, if other people had this too? So that leads to patient mistrust and reduced engagement, because at the end of the day, a lot of people, they'll say, oh, well, I read this on Google, or I heard someone say this, and that reduces them coming to the doctor, learning more about their health, and being more informed.
All right, so this is going to be a little bit interactive. We all know our bodies better than anyone. And let's say you're given a recommendation or a diagnosis, but it doesn't fully capture your concerns. How would you feel, and what would you do? As patients and as patient advocates, we would love to hear from you.
At least one person. We have 2 questions. That's the first one. Anyone? Somebody.
Hand raised.
Anyone?
Hand
Hands raised. Oh.
I would get a second opinion if the diagnosis did not feel like it was in line with what I was experiencing. And I think, like most people, I would research the condition, my symptoms myself.
I'm with you on that. Anybody else? Okay, a second question to follow up with that is, as advocates, we've all been in that patient experience at some point in time. What language, as a medical professional, if we have any in the room, what language would you say we should use, or ensure that we're saying in order to make sure that we're being heard, make sure that our concerns are being addressed? What attitude should we come into the room with when we're discussing things about our health? Any tips that we can share with everyone? Oh yeah, I love the hands. Okay, I'm gonna come this way.
You need to use everyday language, because a lot of people do not understand medical terminology.
So I've been in the healthcare field for 25 years as a nurse and a nursing director, and physicians can be hard to speak with. So if I were advocating for a patient or a patient looking for advice, I would come at it from a point of vulnerability, explaining how I feel and trying to connect with the physician on a personal level. Because if I just show them my online articles that I found, while that should be enough, I'm just not going to get the results that I need.
Love those answers. I'm coming.
So I work in the military health system, and we very often encounter patients who don't understand the system. We have a large proportion of patients who do not speak English as their first language, and so a lot of times the advice we give is so fundamental. I tell them, make a list of your top 3 to 5 complaints. Make sure that when you walk in, you have a list for yourself and a list for the provider, and don't leave until they've addressed each of those issues. And sometimes I think people being visual, that helps them kind of stay on track and not kind of get off on tangents. And also, it helps the provider understand what the patient's real question is if English is kind of a problem.
Right. Okay, I'll take one more because of time. Y'all got me running in this place. Okay. Here you go.
Okay, as a patient and a patient advocate, hopefully I'm answering the question, but going in with data, I always try not to go in the doctors and say I don't feel good. Everybody that goes in the doctor probably says they don't feel good, so having data of oh, I've had a headache for this long and I've experienced these symptoms gives, I feel like, the doctor more information to kind of diagnose what you actually came in there for in the first place.
Yeah. There's already so much knowledge that a doctor has to remember and keep in mind. So coming in with that preliminary information, I believe, helps both sides.
So to lead into this next slide, we're going to talk about patients whose voices hasn't been heard. So just going back to the bias piece that feeds the algorithms. So let's start with race. Race isn't a biological factor. It is a social construct. And so race-based medicine has been practiced for Lord knows how long. And so race, there's been studies, for example, that assumes that race has genetic differences between in different individuals. So it's not a biological factor, and assuming that there are genetic differences based off of this social construct. So if we start with kidney failure, for example, we have Black Americans who are 3 times more likely than white Americans to experience kidney failure. There has been a study that studied creatine function between Black patients and white patients and found that Black patients had higher creatine levels. In that study, there was no talk of diet or other socioeconomic factors that may have impacted why they had higher creatine levels. This then led to a race-adjusted calculation in kidney function. So that would assume that our kidneys function differently. So let's take 14,000 Black kidney transplant patients. To their surprise, found out that they were given credit for lost waiting time, and they have been moved up the priority list. Some folks 2 years and even more, and that was the average. And this is not in 1900s. We're talking in January 2023 to mid-March. Folks realized that they had been impacted by a risk-adjusted calculation. So let's take Jasmine Evans, who waited from 2015 to 2019 for a kidney transplant, and only to learn that due to that race-adjusted algorithm, she could have been placed on the organ transplant list 4 years earlier. And so the race-adjusted guideline is just the tip of the iceberg, one can say. We may have not realized the implications that it may have. The assumption that the race has genetic differences can lead to the misdiagnosis, ineffective treatment. Folks waited 4 years, essentially, to get a kidney that they should have gotten 4 years ago. People could have died, and that leads to the ethical implications and the moral implications. And so talking about this and essentially advocating for ourselves and our patients when, hey, I just don't feel like this is right. Not all hospitals or systems still use race-based adjusted calculation, but plenty still do. And there are a lot of arguments and opposition on why we should continue to use race-based adjusted calculations, because some feel like it supports underrepresented and underserved communities, which we haven't seen thus far. That's exacerbated some health disparities, such as the one that we've seen. So 14,300 patients who needed a kidney had to wait several years than they should have. And so this is just a group, for example, that has impacted by being under-researched or just having some of our own biases play into that research that feeds the systems. And so that automatic notice that said, hey, oh, this patient is fine and can wait, had greater implications that we can see. So now we're going to talk about another group that has been impacted by being under-researched.
Who runs the world? It was a test, I'm just kidding. And unfortunately, on that note, women are severely under-researched. 51% of the population are women, yet we're not in the rooms when these conversations are had. It was only about 50 years ago since we were even allowed to vote. And this picture basically depicts common diseases that women suffer from: cardiovascular disease, HIV, chronic kidney disease, hepatitis, and digestive diseases. And the green dot shows the percentage of women who actually suffer from these diseases. And the orange dot shows how many women are actually participating in clinical trials surrounding the disease. And we can see there's a huge gap between those numbers. So yet there are so many women suffering in silence over these diseases, yet they're not even in the rooms when these diseases are being discussed. There needs to be more awareness brought to this because it's very alarming that we're not having these conversations. And I guess this figure is just to bring awareness to that, to another group, because if we're creating data, if we're informing these CDS systems with data about women, what data are they actually using if we're not actually being researched enough, you know? And then when those solutions are being given to us and we're like, this doesn't match me, this doesn't match my symptoms, we wonder why, because the data is not sufficiently supported.
So sex is a biological factor. So we just talked about a social construct, and then we are now talking about a biological factor. And it is kind of insane to me how we didn't decide to look at the differences, at least between men and women. And it's even apparent in the presence. So when we talk about just not only the cardiovascular conditions, we talk about the gynecological issues, the reproductive issues. 1 in 3 women have those issues, and yet underfunded. We look at autoimmune diseases, where 8% of the US population, or just the population in general, have autoimmune disorders, but 78% of that are women. And some people to this day are diagnosed with undifferentiated autoimmune disorders because, again, understudied. And so when we looked at underfunded, there's been a lot of studies that show male-dominated conditions have greater funding than women-dominated conditions and diseases. And so when we look at that, that leads to the treatment options. If it hasn't been researched, it hasn't been, accepted, then what treatment is being given? And so we find that there's a lot of folks dissatisfied with their treatment, whether it's with endometriosis. Some folks are told, wait till you conceive until, we can further treat you. And it wasn't until 2016 that NIH instituted that sex as a biological variable be factored into its funded research. And that is in 2016, okay? So can only imagine the impacts of the studies that we've been looking at. And there's been several different reasons why women are under-researched. Some researchers have said that it is costly because of the hormones, whether due to menopause or menstrual cycle, on why they don't include them in research, because it can confound due to hormones. And that includes even in female mice. And so it's just been really interesting to kind of discover why this disparity exists, but we are seeing that more and more organizations and research is being put out there, but just not enough and not at the pace that I think as a society that we need.
Okay, so just back to our title, the Bridging the Gap Between, we decided to focus on 2 factors that essentially align CDS systems and what the patient needs, what the patient wants. And we're going to talk about clinical research factors and a healthcare delivery model that we all love, patient-centered care. So off the tangent that Maureen was on about how things are just getting established, things are just rolling. The FDA in June of 2024, this year, they released a requirement for medical product companies that participate in clinical trials and any type of human experiment, that they have to submit a diversity action plan. It's now required, just now, and we've been talking about diversity for ages and ages and ages. And when we think of that diversity plan, it's not only about, once again, race, gender, age, but even about ableism and socioeconomic factors, as we see on the picture to the right. These companies are required now to kind of explain how they plan to ensure that the participants that these diseases that they're researching, the participants that are directly affected by these the participants that are directly affected by these diseases, that they're actually being included in the research. And when we talk about inclusivity, and DEI initiatives, it's always around race. But there's other aspects that need to be considered when we talk about inclusion, such as sex, gender, socioeconomic factors like I mentioned before. And I want to use this moment to highlight just a couple of organizations or initiatives that are out there on this slide, starting with Patients as Partners in Clinical Research Conference. And it's a conference that they put the patient voice on the same level as industry and government. So that allows patients to be in the room, patients to empower and encourage each other in order to participate into these trials, because when they participate in these trials, we can get that data that we need to supply these CDS systems, and they can better align with patient desires. When we talk about community engagement, Acclinate, the company I represent, as well as they have a specific initiative called the Now Included Community Initiative, where they have conversations. Imagine a black man who is disproportionately affected by prostate cancer, sitting in the room with other black men, having conversations about his journey with prostate cancer, and other people around will feel comfortable to explain, like, hey, I know an uncle, or I know someone who passed away from this. What can I do to help me, improve my chances, or whatever the case is. Those conversations can be had, and when those conversations are had, once again, the data that we're looking for are within those conversations. As advocates, if we're in the room with them, we can get more information that we need to better serve our community. And when we talk about education, advocates need to equip themselves with the information regarding SDOH factors. So I know we mentioned earlier in earlier sessions about patients having issues with transportation. If we're in the room when they're talking about these things, we can know, like, hey, okay, at what point do we need to meet this patient's needs and further help them to get more involved and help align their patient desires.
So there are a lot of studies growing around bias mitigation in these systems. And so we can see in 2011, there was probably hardly anything around bias mitigation. Now it's 2022, and we're seeing the growth in researching the application, the tool, the framework, which is an amazing thing because everything is being digitized these days. And again, we as people are informing the creations of these systems and algorithms, and we all have our own biases that essentially translate into these platforms. And so now that we're seeing more research and studies showing the bias mitigation, I think that's great, bringing forth opportunities that we all have. And so there is an initiative called Valid AI, where hospitals and university health technology experts are creating alliances, having open collaboration, which is something I honestly haven't really seen before, where people from different parts of the country are talking about the biases that they're seeing, opportunities that they can have to shape the future of Gen AI. And so this is just a drop in the bucket of different initiatives that are occurring. A lot of grant opportunities are being put to look at research and identify race-based algorithms or different algorithms that are skewed to a specific population, and bringing those out and really looking at opportunities to mitigate them. But we don't have the answers to all conditions and all diseases right now, and that evidence is not necessarily being input in the system. And so right now, using a patient-centered care model where providers and patients can work collaboratively together in the interim, so patients who have autoimmune disorders sometimes, again, have to be their care manager. And so having to have all the providers in a room, and what can we do in that space?
And as we're wrapping up, we wanted to attack this idea by looking at what a provider can do, what a patient can do, and how alignment of those two things can bridge success. So I would say we all qualify to be on the provider side, whether you're a medical professional, independent advocate, you're anything really. We're all on the provider side, and we all at one point have been on the patient side. So starting with leading with empathy, I know that's a very foundational fundamental concept, but with healthcare and all the influences from the business side, from the political side, it's kind of hard to remember, leading with empathy, putting yourself in the patient's shoes. And I believe as advocates, the reason why we're here is because we do lead with empathy. That's the only reason why we'll come all the way over here to discuss these things. So just keeping that in mind, that is a big part of aligning CDS systems with patient desires, is to have that mindset. And when we're sitting with that patient, we're sitting with that family, making sure that we're actively listening, having open-ended questions with them, leading, giving them an opportunity to really talk about what they have going on, giving them the opportunity to be transparent about their experiences. It's very important. And when it comes to active participation on both sides, for the patient, when we're on the patient side, being open to hear what the provider is saying, and even as a provider, actively participating with the patient to be sure that whatever they're saying, making them feel important, once again, putting yourself in their shoes so they feel like they're being heard, because that breeds open communication. When a patient is transparent, you get to learn more about their symptoms, learn more about their lives, because sometimes the reason why they have that stomach ache is not because, of the virus. Past the virus, it could be that, they're not eating 3 square meals a day. Now the foundation of what their issue is.
All right, so we have come to the end of the presentation. I think we're running 1 minute. All right, this has been great. Thank you all for coming. I don't know if you have time for 2 questions? 1 question? Anybody have a question?
Any questions? Feel free to follow us on LinkedIn. Is it follow? Add us on LinkedIn. Connect with us on LinkedIn. Okay. And yeah, does anyone have any questions? 1 question, no?
All right. Thank you all so much.